Good afternoon and welcome to today's Recovery Summit, presented by St. Clair County Community Mental Health with support from the St. Clair County Health Department. Hard to believe it's already the 20th of September. We're 3/4 of the way through our Recovery Summit, and we're at today's presentation today is Cannabis Use and Cannabis Use Disorder, Current Trends and Changing Landscape. We're very excited. This was a very popular webinar for folks to want to attend, so we're eager to get going today. I know many of you have been to a lot of these presentations, so we do repeat a couple of general housekeeping and guidelines. So we want to remind everyone that in these webinar series, we do use the chat feature for all questions or comments to our presenters. And our presenter today, Dr. Bonar, will be answering questions as time allows at the end, and she has set aside time. So again, just go ahead and enter your questions for Dr. Bonar in the chat feature. Today's presentation offers one social work continuing education credit and one McBAP credit. If you're requesting professional credits, you must remain on the webinar for the entire time today. If you lose connection for any reason, please just reconnect as soon as possible and we'll be able to give you credit if you're able to reconnect quickly. A survey also will pop up at the conclusion of the webinar. Dr. Bonar and St. Clair County Community Mental Health definitely appreciates any feedback that you have for the webinar and for the Recovery Summit. So please complete it at the end when it pops up. We would really appreciate it. And if you're requesting social work CEs, we do request that you complete the survey as part of the continuing education credits. Now I would like to introduce our presenter today. Dr. Erin Bonar is a licensed clinical psychologist whose work addresses prevention and treatment of substance use disorders in diverse clinical settings and communities. She's received over $15 million in funds from NIH and PCORI to develop and test prevention and treatment interventions, several focused on cannabis use. She's also the content expert in cannabis for the CDC-funded Injury Prevention Center at University of Michigan and part of the leadership team for the Advancing Addiction Care Research and Education Program at the University of Michigan Department of Psychiatry. With that, I'm going to go ahead and put it over to Dr. Bonar and welcome her today and let her have the stage. Good afternoon, Dr. Bonar.
Well, thank you so much. And thank you for that lovely, warm introduction. I'm really excited to share with the group today and appreciate folks listening and putting a few things in the chat when they come up. So today I do hope to provide some information on cannabis use that can be helpful in your clinical practice or in other areas that folks are tuning in from. In terms of disclosures, I have no financial relationships related to this activity to disclose, but I will note that I do receive grant support from the National Institute on Alcohol Abuse and Alcoholism and the National Institute on Drug Abuse, and that my day job is at University of Michigan in the Department of Psychiatry in our My Acre program. And I do consulting for a group called Prevention Strategies that focuses on an opioid prevention app. So those are my potential biases, if not. I really want to include here two sources. These are my resources that I use as my go-to for finding answers about cannabis, for finding out the facts when I'm uncertain. First, on the left is the National Academy of Sciences report on the health effects of cannabis. So this is a very comprehensive, what one might say, encyclopedia of the research on health impacts of cannabis, from the potential medical benefits to the harms that we may be discussing today. This was published in 2016. They're actually working on an updated version to be released in the coming years because there's a very robust amount of research now going into cannabis that wasn't around in 2016. The other really go-to text is the National Survey on Drug Use and Health. This is an annual epidemiological survey that's nationally representative and provides some state level data that's representative of the state. So you'll hear some Michigan specific data today from this publicly available data at your fingertips as well. If you Google for it, you can find way more information than you probably ever wanted to know. In addition, I like to note that there's a really great article. I have put the title and citation on my slide from Connor and colleagues that I feel like is just such a great overview of everything you need to know about cannabis, from the biology to the health effects. So those are resources I want people to know about. In terms of a couple of disclaimers for my talk today, I would say, one of the bummers about this field is that data lags behind publication, or that, we are still not getting like today's data. We see things that are a few years old. So keep that in mind. I'm presenting you the most recent data, but the most recent data isn't this year's data. Also, I'll say, in my expertise, the frame in which I will be talking with you all today, I'm a psychologist. I do psychological and behavioral research. That's sort of the impacts of I study with regard to cannabis use. And so I'm not an expert in all aspects of the physical or medical pieces of THC consumption. So, but I hope to give you at least the behavioral side of things. Although some of the data and reports we discussed today will use the term marijuana, I do want to emphasize that the field is really moving away from this, given the history of marijuana as a term used in Prohibition era propaganda that promoted racism and xenophobia. I'm not going to get into the details of all of that here, but if you would like more information on this, the Guardian article shown on the right really does a very good breakdown of this issue, and the Library of Congress has a very interesting photo gallery and timeline of these events. Suffice it to say, I'll be using the term cannabis today as much as possible. Some of the national surveys and data still says marijuana, so you might see that popping up on slides with images that I've borrowed from resources. So then jumping in, what is cannabis? Cannabis is a broad term for products that come from the cannabis sativa plant, which can include medical, recreational, and other industrial products. So for the purposes of our talk today, we're focused on psychoactive formulations of cannabis, specifically those containing the cannabinoid delta-9 THC, which is generally responsible for cannabis intoxication or getting people high. We won't be discussing CBD products. These are products that have no or trace amounts of THC in them. There's a lot of interest in CBD for its therapeutic effects. It doesn't really produce a euphoria or a high, and it has a low potential for abuse or dependence. So not the focus of our talk today, but the key concern when thinking about CBD and when you encounter folks who may be using CBD is around the normalization of cannabis products, that we're starting to see these as sort of harmless products, which CBD doesn't carry a lot of liability, but might be sort of priming people to be thinking more about cannabis and use of cannabis. In terms of a big picture, these statistics come from the UN Office on Drugs and Crime, and most recent data being 2022. Cannabis is the third most common controlled substance used in the world. It's used by about 4% of the global population. Cannabis use prevalence has increased 23% globally since 2010. That's in contrast to the number of people has only increased 13%. So cannabis use is outpacing population growth. And 23.8 million people have a cannabis use disorder. That's 303 cases per 100,000. Now focusing in on United States data, again, that data lagged from a few years. 2021 is the recent NSDA data. Shown here, you can see that the majority of the population, ages 12 and older, do not use drugs. But there are about 52 million people in the US who used cannabis in the past year, more so than other drugs that are of concern recently, like prescription opioids and heroin. Here you can see the breakdown of prevalence of cannabis use by racial and ethnic groups in the US, demonstrating some potential disparities. For example, about a third of non-Hispanic American, India, Alaskan, Native, and multiracial individuals report past year cannabis use, whereas other groups like Hispanic individuals and non-Hispanic white and Black individuals are a bit closer to the national rate of cannabis consumption, and the lowest rates are among non-Hispanic Asian groups. When you look at time trends in the US in general, you can see that among those 12 and older, and that's in the red triangle line here. Past year use has been increasing a bit. It rose 11% from 11% of the population in 2002 to 17.5% of the population in 2019 and 2020. And then the 2021 rates were more newly released here. So I've sort of plopped them on the side of the graph. They're not embedded in this great graph from NESDA, but you can see that the rate is 18.7% of 12 and older currently with most recent data. So we also have to take COVID into context, and just I'll tell you that the National Survey on Drug Use and Health, the methodology of 2020 was a little bit disrupted. And so we're looking at pre-COVID prevalence of past year use in 2019. The number in 2019 was more than the average from 2002 through 2018, demonstrating a concerning upward trend. In fact, nationally, more people initiated cannabis use, that is, used it for the first time in the past year, than any other substance except alcohol, with 2.6 million in 2021. Again, pre-COVID, there were actually 3.5 million reporting new cannabis use in 2019, and then we bumped down during 2020, but we're seeing the bump up again now with more recent data. Over time, you can see that pre-COVID, this number of new initiates of cannabis use was going up for many years, as shown in that red triangle line for ages 12 and up. And we see that the initiation of cannabis use went down in 2020, which was expected, but we expect again the trend of general increase to be resuming. And most recent data show about 7,000 people per day initiating cannabis use, with the highest rates in 16 and 17-year-olds at 5.2%. Put another way, that means that in 2021, every 12 seconds, someone initiated cannabis use. And in context, people are initiating cannabis more frequently than tobacco and almost as frequently as alcohol, and much more frequently than drugs of abuse that are less commonly consumed, like heroin. And why do we care about the initiation of cannabis use? The key here is that most initiation occurs among youth, teens, and young adults who are still undergoing neuromaturational processes, which can be affected by regular cannabis consumption. The median age of onset for cannabis use is 18 or 19, and the mean is 15 or 16. And data shows that when individuals start using cannabis before age 16, they have increased risk for cannabis use disorder, and they progress more quickly from use to disorder. So we really want to think about ways to delay onset of cannabis use if people are going to be using this substance. Because additionally, onset before age 18 carries with it additional risks, like an increased risk for motor vehicle crash, antisociality, polysubstance use, and school dropout. And there's a key issue here that comes up with regard to legalization of cannabis use. Even though when states legalize, they have legalized for ages 21 and up, there is concern or question about whether that increases consumption among youth. And in this paper referenced at the bottom of this slide, a recent review by my colleague, Kara Struble, really summarizes these nuances quite well. And they note that states with more permissive cannabis policies, so legalization, are associated with having decreases in perceived risk. So people in these states see cannabis as less risky, not so harmful. So when we have sort of cannabis policies that open up access, that coincides with people believing there are no risks to cannabis use. And then when people believe there are no or low risks to something, we tend to see increases in adolescent cannabis use. Of course, this can vary across locations and data sources, but it's a trend to be considerate and concerned of. And when I talk about regulations, essentially there's been a green wave in the United States. As of June 1st, 2023, 23 states, 2 territories, and the District of Columbus had enacted measures to regulate cannabis for adult non-medical use or recreational use. And as of April 24th, 2023, 38 states, 3 territories, and DC allow medical use of cannabis products. So there's only 3 states that show cannabis use as completely illegal. And those are the white states in this map on my slide. Locally, in November 2018, Michigan became the 10th state and the first in the Midwest to pass a recreational cannabis law, creating the Michigan Regulation and Taxation of Marijuana Act with a vote of 56% versus 44%. This law went into effect in December 2018, and recreational dispensaries began opening a year later in December 2019. So this image is actual footage that I took of my television on election night, and you can see that it would not be possible for 99% to vote yes and 79% to vote no. And I think this is a great symbol of what we can see with cannabis use, and maybe we know how the graphics guy at Channel 4 voted, that we're seeing, some errors being made and some judgment and some, attention to detail. Those can be effects of cannabis. Also, we all make typos all the time. So no shade on the graphics guy at Channel 4 for real. But I see this as a great example of some of the things that might come along with cannabis use. And although cannabis remains a Schedule I federally prohibited substance, the 2018 Michigan recreational law and the 2008 medical law in Michigan allows for increased access and exposure to cannabis throughout the state. You can see here that recreational cannabis dispensaries have proliferated across the state. Although individual counties and localities do have jurisdiction and they can decide not to allow recreational cannabis facilities in their areas, you can see here that pretty much no matter where you are, these facilities are quite accessible. As of December 2022, there were 609 retail shops in the state. And if any of you have left your homes during the past 4 years, you likely have noticed cannabis-related advertising throughout the state. When I drive south to visit my family and I cross back from Ohio into Michigan, there are cannabis signs welcoming me at the border. And here you can see 2 side by side that I took in downtown Ann Arbor, demonstrating the dispensary advertising along with some strategically placed public health messaging during the pandemic. There not seem to be any major regulations on cannabis advertising in our state. This is coming up a few snapshots I took in my day-to-day life. One was of plane flying a banner above Arts, Beats, and Eats in Royal Oak, advertising free weed at the House of Dank. I'm not a paid spokesperson for any of these companies. This is a very gigantic billboard. I was overwhelmed by this billboard at a concert that I went to at the Michigan Laundry Amphitheater, where cannabis was actively sold. And the lawn seats, used to be when you went to a concert, your lawn was sponsored by, this alcohol company or that alcohol company. The lawn seats here were sponsored by a dispensary. So we're seeing just this change in our environment. Last weekend, on the way to the Michigan football game at Michigan Stadium in Ann Arbor, we saw this sign to score some weed, not touchdowns, but weed. So this is just a snippet of what we're seeing day to day about cannabis in our state. And in terms of the cannabis industry, Michigan is seeing nearly $2 billion in sales, with over 30,000 full-time members of the cannabis workforce. That's about 8,000 more employees in this industry than there are police and firefighters combined in the state. The industry is growing as well. For example, there have been recent approvals for cannabis consumption lounges where people can partake in cannabis together in a social space. Michigan is one of 10 states that allow cannabis lounges and cafes. As of March, there were 2 in the state, although 21 municipalities have okayed consumption lounges. Lounges cannot sell on site, and alcohol is not allowed on site either. You typically will find a lounge very closely related to or close in location to a dispensary facility. Now, zooming in our state, let's get a picture of how Michigan looks in terms of consumption numbers. The most recent state level data, again, are from 2021, and in Michigan, 23% of our population used cannabis in the past year. In context, the lowest state in the union was Texas at 12.6%, so about half of what we have here. The highest location was DC at 32%. When we look at use rates in Michigan over time, the dark line, that's Michigan, the orange line is the United States, and the gold line or maize line is Midwest. So when we look at these rates, we can see that Michigan is outpacing the Midwest and US as a whole, and that leading up to 2019, use rates were increasing locally. Again, methodological issues mean that we don't have reliable state level data for the year 2020, but the 2021 data, which I placed in green here, shows this continued upward trend. Now, in terms of past month consumption, which is also what epidemiologists refer to as current use, about 18% of our state residents ages 12 or older have used cannabis in the past month. When you break this down, that's about 2/3 to 3/4 of people who used in the past year are currently using, suggesting that it's not occasional use that is happening when people are using, it's that they're habitual, frequent, or regular consumers of cannabis. And again, just put those numbers next to the rest of the US and the Midwest, we are higher, and no pun intended, we have higher rates. Similar to the annual prevalence data in terms of current use, Michigan outpaces the Midwest. And I additionally want to note that from 2018, when Michigan legalized cannabis for recreational sales, now the prevalence has increased to 2021 by about 33%. So that's a pretty significant jump. Expect we'll see similar, or we'll see continued upward trends as the 2022 and 23 data are subsequently released. Here you can see past month use data broken down by age groups with data from 2002 to 2019 in solid lines, and make that jump a year to the most recent data in 2021, which I've indicated with a dotted line and larger markers. What is remarkable is that you're starting to see that increase in consumption post legalization in Michigan. Look at how those lines start to really jump upward. And although adolescent consumption had been sort of relatively stable, that gold line maybe even going down a little bit, if not, maybe declining in recent years, the 2021 data are telling us we might be seeing an increase in adolescent consumption. And by and large, the young adult age range, so that's considered in many spheres to be 18 to 25, that age range or that group accounts for the largest prevalence of use, which has nearly 1 in 3 young adults having consumed marijuana or cannabis in the past month. So now that I've given you all some context regarding the epidemiology of cannabis and the surrounding industry, we'll dive a little bit more into the drug itself. This is a quick pictorial of what cannabis actually does to the body. And this comes from that Connor article that I said is a great primer. THC, so the active or one of the active components of cannabis, the thing that we think of as getting people high, THC activates cannabinoid receptors that are located throughout the person's body, those blue and green spaces on the body map that you see. And it particularly activates or acts on those areas in the more cognitive and motor areas of the brain and in the immune and GI system. It also causes many complex actions on neurotransmitter release in the brain, causing numerous effects on cognition, memory, mood, motor skills, and so on. One important thing I want to point out is that you don't see a lot of activity in the brainstem region for cannabis. So we're less concerned about things like respiratory depression leading to an overdose the way we are with substances such as opioids. And at the same time, we need to be aware that although the lethality of cannabis use is different than other substances we are rightfully concerned about, the big outcome and what I care about and what I think can impact people's lives and well-being is much more common, which is cannabis use disorder. I'll get more to that in a moment. To understand risk for cannabis use disorder in current society, it's important to know more about the products people are using and how they can amplify risk. I generally say that today's cannabis is not your mother's Mary Jane. There are a variety of products and modalities for using cannabis. If you go to a website for a dispensary, you'll see a product classification that looks about like this one on this page. So in addition to flower or your traditional bud, we now have vaping oils, tinctures, topicals, concentrates for dabbing like wax or shatter, and of course, edibles. The edible market is specifically interesting because the foods can be packaged in a way that is appealing to youth and adults alike. As you can see here, there are a number of products that look like junk food or candy to your more high-end looking fruit candies, peanut butter, and olive oil. There are products that can appeal to a variety of aesthetics. For example, the dispensary next to my local Starbucks advertises their sustainably grown, organic, essentially farm-to-table cannabis products. Another important modality to be aware of are dabs, or highly potent products which are concentrated butane hash oil. Dabs can look a bit like earwax or a rock candy, and they're consumed by pulling off a small piece, maybe the size of a Tic Tac or a grain of rice, and heating it to an extremely high temperature using a specifically designed glass bong, commonly called an oil rig. So it's heated in this rig and then the vapors are inhaled. Dabs are highly concentrated forms of THC and have been shown to have a number of adverse outcomes. One study found that dabbing can lead to higher tolerance and worse withdrawal symptoms. Vaping is also a newer modality of cannabis use. Typically, vapes involve a concentrate similar to e-cigs or Juuls, like nicotine products, although there are also dry vapes that use flower. Vaping is different than smoking. It does not involve combustion, so it does lack the toxic byproducts that accompany combustion. So in some ways, it's perceived by individuals to be safer than smoking. It is noted, however, that vaping usually has greater subjective effects, and the cognitive and psychomotor impairment tends to last longer. But this modality has similarities to smoking in that it's rapidly inhaled into the lung and reaches peak concentrations and highs within several minutes. Zooming in on vaping, we can see that among those who report past month cannabis use, vaping is occurring among most teens, or most among teens, I should say, at 40%. So if you're a teen and you're using cannabis, 40% chance that you're vaping it. Which gets lower in the general population to 20% at 12 and older. There's definitely a correlation with age and cannabis vaping. And you've heard me note a few times so far that some of these products have a higher potency. And when I say that, I mean the percentage of the product that is comprised of delta-9 THC. So although the numbers are not directly comparable, you can think of potency as similar to the ABV rating for alcohol. A greater percentage of THC means it's stronger. There are a few papers here that demonstrate how potency is changing in US cannabis. These graphs are from papers that look at the average THC content in cannabis that was seized by the DEA annually. So they test the cannabis to see how much THC is in it. And starting on the left, which is a little maybe small for y'all to see, I'll give you the big picture. In the 1990s, the average for THC potency in cannabis seized by the DEA was 4%. That tripled by 2014 when the data for the first paper was obtained. So that's your graph on the left. And in a follow-up paper that increased to an average of 14% by 2019. That's only reflective of DEA seized cannabis and not necessarily the cannabis that's available on the retail market, which for some products such as dabs can average around 70%. So we've actually seen dab products concentrates in the 90% range. And for flower right now, we can find things anywhere from 25 to 50%. So I mean it when I say that today's cannabis is not your mother's Mary Jane. This is not the strength of the substance that folks here may have grown up seeing at parties and things like this. The cannabis of today that's being used is much stronger than it used to be. And a growing literature is beginning to identify risks specific to high potency cannabis, such as increased rates of cannabis use disorder among adults who use concentrates and impaired executive function and inhibitory motor control for those who smoke higher potency cannabis. This is not by far a perfect analogy, but I thought I'd share an analogy to think about how strong these products are. When I think about flower from the 90s, it's kind of like a Bud Light. It's pretty low potency, low strength. Flower today, if you move over in the graphic to the right, flower today ranges from, a stronger beer like a Bell's Two Hearted, all the way up to a glass of wine or a shot of liquor. So there's a wide variation in the strength of flower. Vapes and edibles, they're more akin to your strong mixed drink, your Long Island iced tea. And dabs and concentrates, those are your Everclear. That's your grain alcohol. They're very strong. And an important point that I want to note, which we see over and over again with drugs of abuse, is that as they are made stronger and more potent, there is greater potential for addiction or a substance use disorder. And it's critical to note that at the same time we're seeing cannabis become more potent, we're also seeing more and more people indicate that they feel there are no harms associated with cannabis use, which is shown by the graph on the left. And cannabis is overwhelmingly seen as less risky than other substances. And what I find problematic with that view, which is also true in some aspects, is that people often associate lower risk with no risk. And instead, we are seeing the potential risk of cannabis increase as it gets stronger. So I think we need to be thinking about all substances of abuse and considering their unique risk profiles from a public health perspective. And importantly, as a group, young adults continue to have the lowest levels of perceived risk of cannabis use, which is concerning for specific reasons, again, given their ongoing brain development. And as I've mentioned, one of the key risks associated with cannabis use is cannabis use disorder. And I want to make an important point here that's true across substances. The majority of people who use a substance, including cannabis, will not experience major problems related to their use. However, for some, cannabis can have critical effects due to short-term and long-term or heavy use. And these can include, again, short-term effects, impaired memory, making it difficult to learn or retain new information, impaired motor coordination, which can impact driving skills and increase risk for injuries, altered judgment, so, kind of getting into riskier situations, making riskier decisions. And in high doses where some of the THC is highly concentrated, there can be acute paranoia and psychosis. The effects of long-term or heavy use include addiction or cannabis use disorder, alterations in brain development, which are strongly associated with initiation of cannabis in adolescence, lower or poorer educational outcome or increased risk of dropping out of school, cognitive impairment with, again, lower IQ among people who are starting to frequently use in adolescence, so during the time of brain development. Overall, diminished life satisfaction and achievement. And this is what gets to my heart as a clinical psychologist who wants to help people meet their values and goals, is that cannabis can get in the way of that, potentially in the long term. Also, symptoms of bronchitis and, of course, increased risk of psychosis disorders such as schizophrenia in those who have a predisposition. And the New England Journal of Medicine review that I've shown here, has pretty significant review of the evidence and the weighting of the confidence in their judgments about these risks. And generally, most of these risks I've mentioned seem to have a lot of evidence supporting them as true. And in terms of consequences, a recent meta-analysis showed that about 22% of people who use cannabis have a cannabis use disorder. And when people start using in their teens, their risk is heightened. It's about 33% among young adults who use regularly and between 25 to 50% for people who use daily. Cannabis use disorder is a serious psychiatric condition that involves the continued use of cannabis despite impairment in psychological, physical, and/or social functioning. Symptoms are classified based on the DSM-5. Under impaired control, you're looking at symptoms of CUD being cannabis being taken in larger amounts over a longer time than intended, persistent desire or failed attempts to cut down or control consumption, that a lot of time is spent in activities involving cannabis, getting cannabis, using it or recovering, craving, as well as, or a strong desire to use. In the social and physical risk domain, we can see symptoms of recurrent use getting in the way of fulfilling important obligations like work or school or home life obligations. Continued use despite recurrent problems that are either caused by or exacerbated by cannabis. Giving up important activities in the social, occupational, or recreational realms. Current use in which cannabis is physically hazardous. Continued use despite knowing that problems are being caused by the cannabis. And then, of course, the physiological symptoms of depression, of dependence, which are tolerance and withdrawal. Our most recent national data show that cannabis use disorder is prevalent in about, again, nationally, cannabis use disorder, 6% of individuals 12 and older. You can see this in contrast to other substances, which are arguably more deadly and at the same time less common. And again, that spike in 18 to 25-year-olds is much higher in prevalence of cannabis use disorder. This is a comparison of the cannabis use disorder prevalence nationally from 2011 in the yellow to 2021 in the blue. And you can see that across the total population, the 12 to 17-year-olds, 18 to 25-year-olds, and the 26 and up, significant jumps in prevalence of cannabis use disorder over time. There's a wide range of biological factors or psychological factors and social factors that shape an individual's vulnerability to cannabis use. Repeated exposure to sufficiently high doses of THC for an extended period, months or years, can result in adverse acute and long-term mental, physical, and social consequences. With cannabis use, chemical alterations of the nervous system function can occur in the brain, and learning mechanisms impacted by cannabis use, such as cue reactivity and operant learning, further explain long-lasting behavioral changes. The disease model here involves dynamic changes over the lifespan. Of course, stressors and different protective factors can modify the severity of dependence. And there are many changes in the direction of a pathway or a way to exit the pathway toward cannabis use disorder at different points in the lifetime. And vulnerability and risk factors can vary across populations. Further, we're seeing that potency and frequency of use matter with regard to CUD risk. Remember, I showed you the graphic of potency increasing since the 1990s. So in 1992, lifetime risk for CUD was 9%. Now it's 30%. Vaping among youth, as well as other higher potency modalities, is driving increased concerns about these rates. In addition, risk for CUD increases as frequency of use increases. This is critical because daily use of cannabis is increasing these days. Further, co-use with tobacco, one of the other top 3 substances used in the US, increases risk for CUD and is associated with more withdrawal symptoms and reduced success with quit attempts. And I mentioned withdrawal. This is related to a common myth I hear about cannabis use, which is that cannabis use is not addictive and that people can't experience dependence or the associated withdrawal. This is simply not true, as evidence supports that the key facets of addiction, tolerance and withdrawal, do occur with prolonged cannabis use. The issue is that the major drivers of withdrawal are mood and behavioral symptoms, as opposed to the more physiological symptoms that you see with alcohol and other drugs. Here you can see the symptoms of cannabis withdrawal, which include after cessation of heavy prolonged use, potential signs and symptoms developing within a week that are irritability, anger, aggression, nervous anxiety, sleep problems, decreased appetite or weight loss, restlessness, depressed mood, and a number of physical symptoms. So as a practical point for those of you who work in different clinical settings in your own practice, if you see a patient presenting with these types of complaints, given the rates of cannabis use in our community, it could be important to rule out or rule in to ask about their cannabis use and whether they use and or have made changes to their use recently, which could result in these symptoms. I also want to point out that cannabis use disorder can carry risk for several comorbidities. So in Australia, we see 7 in 10 people with CUD having a co-occurring psychiatric disorder. In the US, data suggests that CUD is associated with significantly increased odds of mood disorders, anxiety disorders, PTSD, personality disorders, and other substance use disorders. To me, anxiety is of interest because about 40% of people with CUD have an anxiety disorder, and I clinically see a lot of folks who have anxiety and cannabis use disorder and experience those anxiety-like symptoms if they stop cannabis use disorder, which they believe or experience as their anxiety coming back when it's a symptom of withdrawal. And that's a vicious cycle for trying to help people recover. And on the flip, among people who have other diagnoses you might come across in different settings, there are also an increased risk of CUD. So for example, about 12% of people with major depression have CUD, 20% with bipolar, 26% with schizophrenia, about 10% with PTSD. So it's important to, no matter where you're working, to be considering the role of cannabis use disorder in your patient's health and well-being. And again, this figure illustrates how most of the general population abstains or engages in low risk use of cannabis. They are not in need of treatment or interventions. But as we work up the pyramid, there are fewer people in each level, but with increasing problem severity and a higher level of treatment need. And this is coupled with low rates of treatment seeking and other barriers to treatment like access and affordability. The U.S. Preventive Services Task Force and others recommend routine screening for cannabis use problems as part of primary care, but one could argue it's important in any clinical or healthcare setting. And good clinical practice indicates that we should be asking patients about cannabis separately from other drugs. When you ask a patient, do you use any drugs? That complicates the picture for those who do not view cannabis as a drug, or for those who maybe heard it's medicinal. At a minimum, if someone's using cannabis, it's recommended to assess quantity, frequency, and how they use it, or their mode of administration. It's also helpful to obtain estimates of potency, as this can facilitate a harm reduction approach. And packaged THC products now include labeling of an estimated THC potency. And one of the key things to keep in mind is that by asking about cannabis use, you can start to normalize bringing it up as a part of routine care. In terms of practical advice of how to bring this up in a conversation, let's say with a patient in a clinical setting, you can simply start by asking how often a person used cannabis in the past year. This single item is more effective than using multi-item measures, and if someone seems to be using more than occasionally, inquiring more can help begin to capture an understanding of the role of cannabis in their life. It's recommended to follow up with a symptom checklist of diagnostic criteria that can be then used to guide patient-centered conversations around cannabis and concerns about use, and other ways to potentially address motivations behind cannabis use. Here you can see the elements that would go into a more comprehensive assessment of cannabis use disorder, which is more likely to be the case in a substance use or mental health treatment setting. However, as shown here, I've indicated some of the areas that would be helpful in maybe primary care or other settings, specifically gaining a clinical history of use, any harms or consequences associated with use, and examining specific CUD diagnostic criteria, as shown on earlier slides. Another tool that can be helpful is the CUDID, or the Cannabis Use Disorder Identification Test, which is free and publicly available if you Google this. And as you can see, the items reflect mostly CUD symptoms. And if this is administered and a person scores at least a 13, it can be seen as highly indicative of a cannabis use disorder. And next, I want to share some ideas that can be used when working with someone to reduce harm associated with cannabis use. These guidelines comprise 10 recommendations that are similar to the low-risk guidelines you see for things related to alcohol or nutrition. And the guidelines assume that individuals who continue to use cannabis despite perhaps any advice to abstain, they may be prepared to modify their use to minimize harms, including CUD development. These guidelines include ideas such as using lower potency products, limiting days of use or times of day, and so on. And additionally, before I jump into driving, another strategy that can be useful is called a tolerance break or a T break. And this is a period of time when a cannabis using individual abstains for several days or a few weeks in order to reset their tolerance to avoid gaining too high of a tolerance. Now, another thing I find important to cover with patients is their understanding of cannabis and driving, and the recommendation not to drive for maybe several hours after using cannabis. And honestly, in Michigan, there is no safe level of THC deemed by the government, and people can incur legal consequences if cannabis is shown in their bodies when they incur an infraction, even if they were not high at the time. Many people tell me they feel like they're better drivers when they use cannabis, that they slow down and pay more attention, and that being a little paranoid means they're looking out for the police so they don't get caught. Objectively, cannabis impairs coordination and reaction time, which are sort of the key things we need to have in our favor when driving. So the analogy often used to put this into context is that when you think about the drunk driver, the alcohol drunk driver, the person is swerving, they're blowing through the red light at high speeds. And the high driver is the one sitting at the stop sign, waiting for it to turn green. So driving impaired looks different depending on the impacts of a substance. One of the things you can do as a provider with individuals who use cannabis is to plant some seeds that might alter conceptions about the risk of driving. This is something that people can have misconceptions about, but the goal is not to start an argument. Instead, I often address this topic using a tool from motivational interviewing called Elicit, Provide, Elicit. So I first elicit what people know about possible risks of driving after using cannabis. And if they have a sense of it, I reinforce that. And then I provide a little more information by saying something like, sometimes people are surprised when they learn that cannabis actually slows reaction time and coordination. These are really subtle effects, but they matter when something unpredictable happens, like a deer jumping out, a cyclist coming out of nowhere, a kid chasing a ball into the street. And I follow up and I make sure that I didn't just provide that information to the person, but I elicit what they make of it and how they might be choosing or thinking about getting around more safely. Another note on risk reduction that you can talk to your patients about is if they have kids in the home, to make sure they're locking up their cannabis safely to avoid accidental ingestion by children, especially because some of those products I showed you can sometimes look very appealing to children. In fact, one of the things that often happens after legalization of cannabis in a state is that there's an increase in emergency department visits and poison control phone calls due to ingestion of highly potent products by kids. Finally, another option for individuals to reduce risk of cannabis use is to review and engage in some protective behavioral strategies. You can see a list here of strategies. They're from the Pedersen article cited at the bottom. And these strategies are designed to limit consumption or avoid harms, such as avoiding using at certain times of day, limiting use in public, and so on, avoiding co-ingestion with other substances. In terms of cannabis use disorder, there are effective treatments available as described here in a recent meta-analysis and summary of the literature. By far, the best evidence supports that individuals with CUD should be referred to cognitive behavioral therapy and/or motivational interviewing or motivational enhancement therapy or contingency management, although this contingency management is not widely available. There's limited evidence supporting other approaches, including reliance on mutual help groups like Marijuana Anonymous, although that can be a beneficial support for some folks. It's important to keep in mind, like other drugs and alcohol, that most patients do not reach sustained abstinence, which is often not their treatment goal. The goal of therapy, at least initially, should be to increase the duration of abstinence, decrease the frequency of use, and to reduce CUD symptoms and improve psychosocial functioning. In terms of medication, this is something that people inquire about. So we have great psychological or psychosocial treatments, but for medication, current data is limited. A 2019 systematic review show incomplete and low quality evidence for any medication treatments. It was suggested in this review that antidepressants or anxiolytics really don't have much value in treating CUD, but may be helpful in addressing, of course, comorbid mental health concerns. Some THC-based formulations and anticonvulsants and mood stabilizers can help to manage withdrawal symptoms. So we've seen that that may be useful for a short period of time, but not necessarily a long-term treatment. And so this review concluded that psychological treatments really have the best and most robust evidence for treating cannabis use disorder. So the best options are to refer people to substance use treatment and or trained psychotherapists who use cognitive, behavioral, and motivational approaches. And these are quite commonly available in the community. And finally, in terms of what I hope to conclude and have you walk away with as you think more about cannabis use in your practice, it's to keep in mind that cannabis use is increasing, potency is increasing, and yet most people view cannabis as harmless. Given the relationship between potency and CUD onset, we need to enact prevention approaches and be prepared to manage CUD clinically. And that the best studies, treatment studies to date involve cognitive behavioral therapy and motivational interviewing or motivational enhancement. The good news is that these treatments are widely implemented in other areas and are likely known skill sets to many clinicians, and treatment can be located through insurance networks or the SAMHSA treatment locator shown at the bottom of the page here. And with that, I thank you all for your time and attention and letting me kind of cover a range of topics. I see there's a lot of activity in the chat, and so I will be ready to attempt to answer any questions you might have to the best of my ability. So, does my moderator want to ask questions, or should I pick some out of the chat?
We can go ahead and ask a couple questions, unless you see some that stick out that you would like to go ahead with.
I will. There's one I'll go ahead with, and then I'm happy to have y'all who've been monitoring throughout ask a few more. Saw one that asked what U of M offers for students. So U of M has different programs in their health services, Wolverine Wellness, the Collegiate Recovery Program, and through our psychiatric clinic, substance use clinic, UMATS, University of Michigan Addiction Treatment Services. So there are programs to address substance use, including cannabis use, and you should be pretty readily available if you're looking to refer someone on various websites for both campus health and Department of Psychiatry in the medical school. But I'm happy to see what else was maybe a hot topic during the rest of the chat.
Okay, there's the first question I'm seeing is there evidence to support an actual increase since legalization, or are people more likely to admit to use with legalization?
So you're asking a great question, which is, are the trends that we're seeing due to increased acceptability, normalization, and lack of consequences for cannabis use that maybe people are now just admitting or sharing that they use more frequently than ever before? And that's certainly a possible reason that maybe some reports are increasing. I think the thing that tells us that people are probably using more, that there's that upward trend, has more to do with the fact that we're seeing the upward trend in cannabis use disorder, which is not something, given the stigma associated with cannabis or associated with substance use disorders, that's not something we'd see necessarily might change just because it's legal. I think that, there's more nuance there. But you raise a really good point about that we have to really be thoughtful about why we might be seeing changes in rates. We're seeing everything else go up. So I think the fact that things are more accessible, just meaning more people can get to something because it's not only a, unregulated market, suggests that with access, there's probably increased consumption, but there are also probably people who are now more likely to just say, yeah, I use, it's no big deal, it's legal. So good point.
We have another question. Is Congress planning to change marijuana's classification to a Schedule III drug? If so, what other drugs are Schedule IIIs?
So that's a great question, and I'm not a policy expert. I feel like Congress right now is focused on, figuring out if they're going to shut down or not. So there has been discussion that I'm aware of, probably as much as anyone else who reads the news, that it may be they may drop it from Schedule I, which is like the most illegal type of drug, to more of a controlled substance. So some of our other prescription drugs you may get that are controlled substances might fall under Schedule III.
Is there evidence that marijuana is a gateway drug?
The gateway drug is an interesting thing, and I feel like that's a topic or a moniker that's left over from the drug war that I grew up with. Basically, cannabis is a substance that some people use before other substances. Doesn't mean that everyone who uses cannabis is going to go on to develop, a serious drug use disorder and use all the drugs. Similar, people use alcohol, people use tobacco, and typically the first drug someone uses is their gateway to other exposures that increase their risk of developing or using new substances. That's really has to do with where do you end up? So if you first encounter alcohol and then you start hanging out as a teen with people who use more substances, you might, then turn to the next substance that's available to you. But if you don't have access, you don't use the substance. And so I think the gateway theory is a little overly blaming, and that it's not the case. And remember, most people who use drugs do not have problems with drugs, and that it's a small group of people that go on to develop problems. Now, I care about that group at a population level, but we don't want to think about demonizing every time a person uses a substance as a potential gateway. Then we might be sort of missing and not focusing on the risk or the risk groups or the disparity groups that need the most.
Okay. So there is another question. How much of those statistics are controlling for cannabis use that began as a self-medicating coping mechanism for psychological symptoms? Has research been able to tease out how much is I don't know, I can't say that word, versus just correlation? Sorry.
That's a lot of the data I showed you today was epidemiological. So that's getting at what are the rates of things on a population level. When we look at data that is among people who use cannabis, one of the key reasons, one of the things that pops up over and over in our work, both when we're looking at daily data versus over longer periods of time, is using to regulate negative affect. So using to cope with something. Medical use also important, to using to address a medical problem. So that's a big part of why people consume substances, definitely because you're getting an altered effect. Coping being one of the ones that is more associated with negative outcomes than, say, other types of motivations for use. And there are whole motivational theories of substance use that have to do with positive and negative affect regulation. Typically, across substances, using for coping is associated with greater risk for problems later on. And so I think we need to be doing something about mental health and pain and other things that maybe are putting people in a position where they're looking for solutions to feel better.
Do you see any data on persons using while working? Is this considered impaired?
That's a great question. So one of the things that's interesting about that, I don't know of a national level sort of data, but I clinically hear about this and see it. And then as a person existing in a state with high cannabis use, know about it from people that I've come across. So it definitely happens. And I think depending on the tasks and the level of consumption, it does cause impairment. And so again, I think about those people that are in positions where they need those cognitive functions that are important, like driving, or, thinking things through and reacting quickly, that being high is going to diminish that capacity to some degree.
Thank you so much. That is a lot of really good information. There's a lot of thank yous in the chat, and people are asking about the slides and
I'll send them out.
recording. Yeah, so they will, the recording will be available on the SCC CMH YouTube channel, and we will make the slides also available probably within the next week or so. So I just want to thank you so much for coming today and sharing this information. I just want to thank everybody that attended today. If you've requested professional credits, you'll get your certificate by the end of October via email. And thank you again, Dr. Bonar, for your presentation. And
Thank you so much, everyone. Thank you.
Thank you, everyone that attended today, and have a great day.